time to start the session Euro-PCR, the Gulf meeting, and really I would like to thank Professor Abinali and all the organizing committee for giving us this opportunity to share with the Euro-PCR organization this session. This session will be dedicated on the problem of multivessel disease, and what we want to do is from two live cases to discuss, of course, how to do the decision making for the patient, coming from the clinical presentation of the patient, angiographic characteristic, biology, etc. That is called a global appraisal of the patient, and how to move to the decision making, then how to perform the PCI procedure, and we could discuss also the post-PCI treatment. In preamble, I would like to tell you this, and this is on the lateral screen. Our intention in Euro-PCR meeting is not to teach you a method that you must follow in order to reason, but simply to show you how we try to conduct our reasoning. And this, I think, is the most important, particularly when we talk about education, medical education of adult, which is totally different of education for fellows. We have to try to show a type of reasonment that we have to do for each individual patient. So you know that for the patient with multivessel disease, some of them are candidate for optimal medical therapy, some of them are candidate for PCI, and some of them are candidate for bypass surgery. So our objective is to propose the best option adapted for each individual patient for each particular situation. So what we can do after this preamble is to start the first case. I'm really happy to have with me today to share this session Dr. Hassan, Dr. Mohamed Sobi, and Ibrahim Al-Rajdam. And we will try together to have really an interactive session. When I say interactive, we have the possibility during the demonstration to stop the video when you want. So if you disagree, if you have a question, you say, have the hand, and you say, stop, we stop the video and we discuss together, okay? The goal of this session is to have an interactive session. Okay, so if you agree, we can start the first case. So we planned two cases. We have plenty of time. Each case on the video is around 30-35 minutes, and we plan 1 hour for each case. So we have time for discussion. So we start by the first video. I hope it will work. So for this Like in the Box session, we have the pleasure today to have two guest operators. Martin Thomas at the table. He will work with my partner Didier Cheche, and Peter de Jager from Rotterdam. I will introduce the team. Our cardiac anesthetist working with us will be Madi, and we have three nurses with us, Brigitte, Nelly, and Véronique. First of all, the case will be presented by one of our fellow. Fleur, can you present the case?
Hello, so this patient is a man, 82 years old. His main comorbidities are hypertension and chronic atrial fibrillation treated by Coumadin. So he presented an acute pulmonary edema a few days ago with electric modification in apical lateral leads. The laboratory exams find basically a slight increase of troponin and an increase of the pro-BNP. Moderate renal failure. The echo shows LV function nearly normal but hypertrophic. The baseline angiogram shows an intermediate lesion of an obtuse marginal and two severe lesions, two severe stenosis of the LD, very calcified and long, two calcified bifurcation lesions. Here again, and also a significant stenosis of distal RCA. So we first decided to treat in the same time the distal RCA with a bare metal stent. The risk evaluation, so the scores, Euro score nearly 7% and the STR score 7.5%. The syntax score has been calculated also 19. The key points, so bypass or PCI, and how can we prepare, how can we treat this mid-LAD, this severe lesion, calcified lesion.
Okay, thank you, Fleur, for this nice presentation. Peter, how can summarize this patient and how could we treat him?
Well, so in summary, it's an old man, 82 years old, that also reflects his high likelihood of having calcification, which has been shown on the angiogram. And I think that is the Achilles heel of this PCA. The first question that was asked, should we go for bypass or PCA? For me, it's clear. Given the anatomy, I would go for a PCA. And basically, you have started this strategy by first securing the right. And there you have chosen the bare metal stent, which to me makes sense, given his AFib for which he receives Coumadin, which means that we're entering in another discussion, the post-treatment, giving his Coumadin, and if you would choose a drug-eluting stent, that raises the discussion of the antiplatelets and the Coumadins. But to come back to the question you're specifically asking, the LED, it is over a long trajectory calcified. There are two lesions. So I would not be amazed whether you would have a strategy to, and rather than doing a balloon dilatation with the risk of inducing a calcification, that you're going to use another technology to safely widen that artery and then proceed with stent implantation. And I think you could think of a...
So I think we can stop the presentation at one time. Have you any comment in the panel? Ibrahim, Mohamed Hassan?
Yes, I think even before getting into the technique here, before to get into the technique of how to address this issue, I think the operators, when they did the angiography to start with, they have done PCI of the RCA. So the decision to carry on with PCI was taken, even in the previous diagnostic angiogram. Because if you think to do, for example, or think to consider bypass surgery, you would not have treated the RCA. So I would think that in my situation, if I'm considering bypass surgery, I would not treat the RCA. I would consider bypass to start with and discuss with the patient. But in my country, 82 years old is very old. They would not allow us to send the patient for surgery. But I don't know, in France, maybe it is different.
Yeah, so what's happened in this situation, and happened really in routine everyday practice, when we have this kind of patient, we call the surgeon, and we are at the really two different, we are the lower part of the building, there are the first floor, so there is direct stairs to descend in the cath lab. So we have, we are connected with the surgeon in day-to-day practice, non-stop in the day. So in this particular situation, when we have we have done the coronary angiography, we call the surgeon and say, okay, he's 80 old. We come back to the clinical presentation, saw the angiography, and at the end, the surgeon, what you say, okay, it's 82. There is some distal lesion on the distal LAD, which is heavy calcified. So there was a problem for the Lima. The right coronary artery was not a problem. The OM branch could be also bypassed without any problem. Really, the surgeon was not optimistic because of the calcified LAD. That's the reason why we decide. to move first for the what we call the culprit lesion towards the right coronary artery, and then to do in the second step the left coronary system because of the age of the patient. The credence creatinine was around 50, so we have to take care of the amount of contrast media we have done. Any question concerning the indication first?
Yeah, one question regarding the decision, because already you have a patient with multivessel disease. Already you made a decision for bare metal stent because you cannot continue the dual antiplatelet therapy with warfarin for a year, actually, which increases the risk of bleeding.
And it's
now
82.
the other part of the coin is you have long lesions, calcified, chance of restenosis is very high. So how would you balance this? I mean, why not to go for surgery?
You are absolutely right, and you will see the end of the film.
Okay,
But you are perfectly right. We will discuss this later. You're right.
I think the problem of this patient, it is we don't know where is the culprit vessel at the beginning.
That's true.
It's acute pulmonary edema, good function, ASH, elderly patient with 19 Syntax scores. So it's this, I think, motivates the operators to go with doing PCR and see what's going for the patient next time. This is the reason why he started. But he think about drug-eluting stents again in the next step. The first step, he think about the Coumadin. The next step, the restenosis rate is high, so why are you going to do bare metal? Then I think it'll be discussion with the surgeon whether the risk. So here is 50-50 because this is the only disadvantage of this patient is the elderly, the age for the surgery, and for here the calcification. If you don't have any material to treat with the calcification, I think even with the 82, you can send the patient on beating heart, something like this. So we decide with the surgeon according to the center. Not any center can do what you are going to do.
Yeah, but this is particular patient because when you look at the two lesions on the right and the circumflex, there's two type A lesion, and it's a reason why the global Syntax score is low. But if you consider the LAD, the lesion itself of the LAD, which is a long lesion, mid-segment, and it's quite high, and the risk is quite high. In this lesion, two bifurcation, the septal and the diagonal branch. So it's a particular situation with two type A lesion on the two vessels, and one type C, very complex, on the third one. The other point is that it's true that the Syntax score globally is low, but the Euro score is quite high. That's.
I mean, can you do for this patient hybrid procedures? I mean, two A's and then go for the LAD for the beating heart the 82
absolutely.
years.
This should be a nice indication for the hybrid when you have a complex lesion on the LAD and two type A lesion, simple lesion of the two other vessel. And the hybrid associating a Lima to LAD and two stent on the two other vessel should be a nice procedure. The only point is this calcified LAD, and the surgeon was not enthusiastic to do it. That's a problem. But you're right, should be a good indication it was less calcified. Other comment?
If I may add another point of discussion, if we go back to the principles of managing coronary artery disease in general, it's either the revascularization in general, either PCI versus CABG. Now, we have a gentleman who's 82 years old, he has renal failure, he has complex anatomy. In terms of data, in terms of are we doing this for symptoms or prognosis, number one. Number two, in terms of prognosis, I'm not aware that we have even that we can apply Syntax score on somebody who's 82 years old. The average age in the Syntax data is about 68, if I remember it correctly. So in terms of, I don't think we have enough data to decide which one is the best strategy in terms of prognosis.